Ladies and gentlemen, welcome to live webinar, and this time it is dedicated to challenges in managing lymphomas in 2022 under the aegis of Mumbai Hematology Group. Every day we'll be starting at 6:25 except Tuesday, and it's a marathon again for next 5 days, and we close on Thursday. All courtesy the gentleman which will come in the picture, Professor Dr. M.B. Agrawal sir, and Mumbai Hematology Group. We know him very well, Professor and Head Department of Hematology, Bombay Hospital, and sir is also consulted at prestigious Lilavati Hospital and Bridge Candy Hospital and President of Mumbai Hematology Group. We know him very well, an institution in himself, inspiration for many and teachers of teachers. And India is fortunate to have him had the maximum number of international and national web series and involved the maximum number of medical oncologists and hematologists in the country. COVID time and post-COVID time. No wonder, sir, that you have been awarded the Inspiring Hematologist of India by Economics Times. May I request you to take it forward from here, sir.
Thank you, Dr. Manoj. Good evening to one and all from India. Challenges in managing lymphomas in 2022 with 15 international guest speakers from today until Thursday, that is 11th to 15th of September. We have this marathon lymphoma update beginning at 6:25 almost daily. This webinar is brought to you by Mumbai Hematology Group. It is supported by INTAS. The whole series of these webinars is solely sponsored by INTAS. I'm grateful to Dr. Manoj Kumar for that gesture. It's managed by Perfect Square. I thank Dr. Manoj Kumar and his team from INTAS, Mr. Yash, Mr. Kalpesh and the team from Perfect Square, the Executive Committee of Mumbai Hematology Group, all our faculty members. We are extremely prominent leaders in their own fields. All our discussants who are again eminent hematologists or medical oncologists from India, new participants for sparing your Monday evening from India, maybe morning or afternoon from other countries. Our website is www.mhgindia.com. You can visit it. There is no password, and you will have an exposure to all our future academic activities and also various lectures which have been held in the last few months are over there. Today is day one. We have 3 lectures, beginning with follicular lymphoma by Dr. Nathan Fowler, moving on to marginal zone lymphoma by Dr. Zinjani, and then double refractory Hodgkin lymphoma by Dr. Mehdani. Our first speaker today is Dr. Nathan Fowler. He requires no introduction. He was our guest in Mumbai a couple of years ago. He's going to speak to us on managing follicular lymphoma in 2022. He's Professor of Medicine, Department of Lymphoma and Myeloma, Division of Cancer Medicine at University of Texas MD Anderson Cancer Center, Houston, Texas. He received his MD and completed his residency at the University of Texas before completing a clinical fellowship in hematology oncology at Georgetown University, where he was a chief fellow. His interest in immunomodulatory agents began during his hematology oncology fellowship at George University Hospital, where he helped develop some of the first protocols to use lenalidomide in chronic lymphocytic leukemia. His focus at MD Anderson has been the development of novel approaches for lymphoma, where he led the clinical and translational research program in lymphoma for 10 years, resulting in the discovery and approval of several immunomodulatory and targeted new drugs now used in practice worldwide. He also serves as the chairman of several phase 1 and investigator-initiated phase 2 trials for patients of non-Hodgkin lymphoma. He's written several books and chapters about the treatment of low-grade lymphomas and is a regular speaker at international meetings regarding the development of new drugs in the field of lymphoma. I invite him to deliver the talk on managing follicular lymphoma in 2022. Thank you.
So
So our guest speaker now is Dr. Zinzani from Italy. He will be speaking to us on how do I sequence therapies for marginal zone lymphomas. Dr. Zinzani is head of Lymphoma Group, Lymphoma and Chronic Lymphoproliferative Syndromes Unit, Institute of Hematology, Alle Seraglio, University of Bologna, Bologna. Graduated in Medicine and Surgery with honors at the University of Bologna in 1984. He obtained the specialty in hematology with honors at the University of Bologna in 1987. He was awarded a postdoctoral fellowship in medical oncology released by the Roger Williams Cancer Center of Providence, USA in 1989. Associated Professor at the Institute of Hematology and Medical Oncology, Alle Seraglio, University of Bologna from November 2002. Since 12th of November 2018, is full professor of hematology at the University of Bologna. Served as the principal investigator of over 200 clinical trials, including phase 1 and 2 studies, followed by expansion cohorts in patients with Hodgkin lymphoma, non-Hodgkin lymphoma, CLL, including national, international, multinational studies. President of Italian Foundation on Lymphoma from November 2013 to November 2015, and now he is a member of the board of directors. Associate editor of Annals of Oncology from January 2014 to December 2017, and he acts as a reviewer for journals such as Lancet Oncology, JCO, Blood, Clinical Cancer Research, Cancer, Hematologica, Leukemia and Lymphoma, Leukemia, Clinical Lymphoma, Myeloma, Blood Advance, Lancet Hematology. He has presented his research at more than 470 national and international meetings. He has authored over 670 peer-reviewed papers in journals such as NEJM, Blood, JCO, Lancet Oncology, Annals of Oncology, Oncologist, Journal Hematology and Oncology, Hematologica, Blood Advance. His current research interests include clinical trial methodology, prognostic factors in NHL, Hodgkin's disease, CLL, new drug development, and hairy cell leukemia. I request him to deliver his talk on how do I squeeze therapies for marginal zone lymphoma. Over to you, sir. You can share your screen now.
Do you see my slide?
Not yet, sir.
Now?
Yes, sir. Yes, perfect.
Okay, when you want, I can start.
Start, sir.
So thank you very much for Professor Agarwal for your kind introduction. This is my disclosure. So marginal zone lymphoma represent one of the WHO subtype, and they include 7% of all mature non-Hodgkin lymphoma. There are 3 different subtypes inside marginal zone lymphoma: the extranodal marginal zone lymphoma of mucus-associated lymphoma tissue. They represent about 5% of all non-Hodgkin lymphoma and 70% of all marginal zone lymphoma. The second one is nodal marginal zone lymphoma, roughly 2.5% of all non-Hodgkin lymphoma and 10–15% of all marginal zone lymphoma. And finally, the splenic marginal zone lymphoma that represent less than 1% of all non-Hodgkin lymphoma, and inside marginal zone lymphoma is 10–12%. And you can see here the epidemiology, and the incidence increase with the age in all marginal zone lymphoma subtype, and is represent the third most common B non-Hodgkin lymphoma subtype. The age class specific incident by lymphoma subtype. This was an evaluation from a register of UK. And you can see here the prevalence of follicular lymphoma and marginal zone lymphoma from the same reference in terms of 3-year prevalence, 5-year prevalence, and 10 years. And marginal zone lymphoma include a group of related clinical entities. And of course, as I said before, the 3 most important histological subtypes are extranodal marginal zone, the splenic, and the nodal one. But there is also a leukemic marginal zone lymphoma, entities with bone marrow of blood impairment, and also a disseminated marginal zone lymphoma, represented by spleen involvement with peripheral lymph node, with bone marrow involvement, with leukemic infiltration of the blood, and sometimes you can have also other extranodal site. I will start with the extranodal marginal zone lymphoma, so the mild lymphoma. The histological features are centrocyte-like cells, usually in the majority of the patient. There are lymphoepithelial lesions. There is a plasma cell differentiation. There are some scattered transformed cells, and also a small amount of that mixed reactive T cell, and finally a classical and conventional follicular colonization. These are the molecular pathogenesis of mild marginal zone lymphoma. As you know, there are several infection agents like Helicobacter pylori, Borrelia burgdorferi, Chlamydia psittaci, Campylobacter jejuni, and also hepatitis C virus, and some cases with Acromacter cyclosinans. And also there are some autoantigens like Hashimoto thyroiditis, myoepithelial choroiditides without Sjögren syndromes in the salivary glands, and also in the lung lymphoid interstitial pneumopathy that often are present in patients with mild marginal zone lymphoma. This is the model of tumor progression present in the gastric mild marginal zone lymphoma. You can see here the activity of the Helicobacter pylori, but also there are several other steps represented by the tumor microenvironment, and also a neutrophil activation with free radical release. And step by step, there is a reduction of the antigen dependency, and with the BCR-dependent MFK and KB activation, with some epigenetic change like P16 methylation, and at the same time, there is an important B-cell proliferation. So at the end of the day, you can have also some particular and peculiar translocation like 14-18, 1, 14, and 11, 18. In this case, everything is modulated on the basis of no Helicobacter dependency in this last step. And in patients with the mild gastric mild marginal zone lymphoma, Helicobacter pylori positive, this is the algorithm of the treatment for stage 1A or stage 2. And if there is a positivity, as I said before, the first step is to try to eradicate Helicobacter pylori with standard treatment, so antibiotic plus proton pump inhibitor. And there is an evaluation of a HFP test after 2-3 months, and the second line antibiotic regimen is ready to start if in this for the first time the eradication failed. Again, there is a repetition of AGCD and biopsy at 3 months after the eradication. And in the cases where there is a HFP negativity and also a negativization of lymphoma, there is only observation. On the other hand, for Helicobacter pylori negative, but lymphoma continue to be present when there is an asymptomatic lymphoma or stable situation. You can observe when there is a symptomatic lymphoma, you have to start with other treatment. One of them is radiotherapy, involved field radiotherapy on on the stomach, and the same situation is also for patient HFP pylori positive with lymphoma present. You can use also chemoimmunotherapy and with also the role of rituximab as a single agent. This is according to the ESMO guideline. The complete response after HP eradication is 75%. The relapse is present in roughly 8–10% of the patients. The reduction of Helicobacter pylori prevalence in gastric marginal zone lymphoma is from 61% to 17% in the two different situations in terms of period, from 1997 to 2002, and the second part from 2003 to 2007. Helicobacter pylori negative gastric lymphoma may regress also after anti-Helicobacter pylori therapy, but the percentage of CR is very low, no more than 15%. Another important point, as I said at the beginning of this issue, the infection agent and pathogenetic therapy for marginal zone lymphoma. So I said the Helicobacter pylori in the stomach, and the overall response rate is roughly 78%. There is the Chlamydia psittaci in the ocular adnexa. The treatment is doxycycline or clarithromycin, but in the majority of the patients we try to use clarithromycin, and the overall response rate is roughly 45–50%. Quite rare situation concerning the correlation between Borrelia burgdorferi and skin maltoma. The antibiotic treatment is ceftriaxone, and the overall response rate is roughly 40%. Really few cases for with Campylobacter jejuni and for Acromacter xyloxidans in the lung. And concerning the hepatitis C virus, there are several sites, and the treatment with antiviral therapeutic approaches quite interesting in terms of overall response rate, because it's ranging between 45–70%. In terms of prognosis for extranodal marginal zone lymphoma, there was created also the multi-IPI by Kiepenemonde and co-workers. These data were published on 2017 on blood. You can see here they evaluated more than 400 patients, and the prognostic factor were advanced stage 3 and 4, age more than 70, elevation of LDH, and the validation cohort was done on 633 patients with 3 different mild cohorts, and the training cohort was observed in the ESG-19 study. At the end of the day, you can have a stratification in terms of event-free survival, and also in terms of overall survival according to the IPI low grade, intermediate, and high grade. You can see here that normally 42% are low grade, 41% intermediate, and less than 20% of the patients are high risk according to the Malta IPI. The International Extranodal Lymphoma Study Group 19 study was a randomized study in mild marginal zone lymphoma, comparing in more than 400 patients chlorambucil, the standard arm, versus chlorambucil in combination with rituximab versus rituximab. 3 different arms. You can see here the overall survival. There was no statistically significant difference, but in terms of progression-free survival, after more than 10 years, the combination of rituximab plus chlorambucil is absolutely better, and the 5-year progression-free survival is 72%. In terms of event-free survival, there are small difference between gastric marginal zone lymphoma versus non-gastric, and it seems that the gastric marginal zone lymphoma is a more indolent disease. In terms, this is the last curve concerning the event-free survival, comparing the different sites of the mouth, lung, orbit, salivary, intestine, and skin, and you can see here that the best data are for sure in the skin side and also in the lung side. The International Extranodal Lymphoma Study Group 38 evaluated the potential role of maintenance with rituximab. There was the induction according to the ELSG 19 using rituximab plus chlorambucil. For the patient who obtained at least a partial response, there was a rituximab maintenance for 2 years. The majority of the patients were with non-gastric sites, and 30% of the patients are considered high risk according to the multi-IPI. In particular, there were no new safety signals during the maintenance treatment with rituximab, and the best CR rate was 87%, and in particular, the CR rate at the end of the induction was 53%, and at the end of the maintenance treatment was 65%. So several patients had a conversion rate from PR to CR during the treatment with rituximab. The 5-year event survival was 76%, and the 5-year overall survival was more than 90%. In terms of frontline treatment for advanced stage with mild marginal zone lymphoma, for sure the best therapeutic approach is bendamustine plus rituximab. These are the very important data of the phase 2 study by the Spanish group, the Geltamo. And you can see here the 7-year event-free survival is close to 88%. They included 60 patients. The overall response rate was 100%, and they observed 5 relapse, 3 patients who presented a transformation to diffuse large B-cell lymphoma, and on 36 out of 60 patients had one or more than one adverse event of grade 3 and 4. You can see here also the event-free survival curve according to the mild IPI. There is a very clear stratification in the different subset, and there were no difference between gastric and non-gastric mild marginal zone lymphoma, and the 7-year progression-free survival is close to 93%, and the 7-year overall survival is close to 97%. The second entities of marginal zone lymphoma is the splenic one. Is an indolent non-Hodgkin lymphoma involving spleen, bone marrow, and frequently peripheral blood, with occasional diagnosis due to lymphocytosis. There is a symptomatic splenomegaly and cytopenia with autoimmunity, and the definitive diagnosis is on the basis of the spleen histology. If not available, you can have an integration with of bone marrow histology, with morphology, immunophenotype of bone marrow and peripheral blood, and also some clinical data. The classical immunophenotype is CD19 positive, CD20 positive, CD22 positive, CD23 negative, CD5 negative, with really few patients with the CD5 positive, CD10 negative, and the cyclin D1 negative. There is a presence of marginal zone expansion in the wild pulp inside the spleen, and inside the bone marrow you can have a sinusoidal pattern that is quite nodular. I'm sorry. In terms of prognostic score, also for splenic, there was a publication by Arcani and co-workers on Blood 2006 concerning the evaluation of 3 prognostic factors: the hemoglobin level less than 12 grams per deciliter, the LDL level higher than the normal, and the albumin level less than 3.5 grams per deciliter. And you can see here that there is a good stratification according to the cause of specific survival. And in this kind of evaluation, 41% were low score. Intermediate score was observed in 34% of the patient with only 1 prognostic factor. And when there are 2 or 3 prognostic factors, was considered high risk, and there was represented in 25% of the patient. Generally, there is an indolent course with a median survival of 8 years for the low risk, intermediate risk. And there are, of course, this kind of high risk patient that represent, as I said before, 25%, 30% present, of course, a really worse outcome. And there is also another publication by Montalban and co-workers on leukemia lymphoma 2014 concerning another prognostic score, including anemia, including thrombocytopenia, high level of LDH, and also the presence of extrahilar lymphadenopathy. Also, in this case, there is a stratification in 3 different subsets according to the lymphoma-specific survival. And in this study population, 36% of the patient didn't present any kind of prognostic score. More than 50% had 1 or 2 prognostic factor, and only 8% of the patient present 3 or 4 prognostic factors. In terms of genetic and phenotypic situation in the splenic marginal zone lymphoma, according to the recent publication of the ESLG 46 published on Blood the last year by Bonfiglio and co-worker. Also, it was involved in this trial. And we reached more than 300 fresh spleen samples with splenectomy before 2010. And the diagnosis of splenic marginal zone lymphoma was confirmed by pathological revision. There was a target deep NGS evaluating mutation and CNA, and at the same time there was an evaluation of gene expression profiling by global and targeted RNA sequence. There was also HIV sequences and also several clinical data with a median follow-up after splenectomy of 10.6 years. The second-line treatment after splenectomy in 10% of was observed in 10% of this clinical data. 5% had chemotherapy, other 5% chemotherapy without anti-CD20 monoclonal antibody. There was a machine learning with some evidence of molecular clusters. You can see here the mutational landscape of this study in the splenic marginal zone lymphoma with a different percentage of the gene observed, and also again some more evidence concerning the gene in this mutational landscape. At the end of the day, there are 4 molecular clusters, and we detected a mutation in roughly 87% of the cases, and the 4 molecular clusters are the first NNK, including FRKB, Notch, and KLF2 modules, that represent roughly 58% of the cases, and in this case, potentially the best treatment could be BTK inhibitors. And the second cluster was DMT, including DNA damage, MAPK, TLR node modules that represent 33% of all study population, and potentially on this basis, the best treatment could be BCL2 inhibitors. The third cluster was a CBS, cytokines, BC receptor signaling, and the spliceosome modules that represent more than 5% of the study population. And the last one is the PI3K inhibitor AKT module that represent more than 4%. In this case, again, could be evaluable the potential role of PI3K inhibitors according to this kind of mutation. And in terms of classes, we can have two different classes, two different immune microenvironment classes in terms of phenotype. And the first one is immunosuppressive, 50% of the study population. Macrophages, cytokines, chemokines, and T-cell and Tregs. And it is immune suppressive checkpoint milieu associated with the T-cell exhaustion. And the second one is in the immune silent, that present the other 50%, and with B-cell signature of obvious tumor origin, CD19, CD20, CD79, A and B, and PAX5, with an high ratio of neoplastic to microenvironment cells. In this case, potentially the best treatment in the first immune suppressive classes could be checkpoint inhibitors. The second one, the immune sealant, could be bispecific monoclonal antibody, and why not CAR T-cell. In terms of relative survival according to the clusters, you can see that at the end of the day, for DMT is roughly 86%, for NNK is close to 80%, and according to the two different phenotype, immunosuppressive and immunosilent, there is no an important difference at 10 years in terms of relative survival. For the NK immunosuppressive, the overall survival is roughly 71%. The ESMO guideline for the splenic marginal zone lymphoma in terms of therapeutical approach, you can have asymptomatic patients. In this case, watch and wait is the best therapeutical approach. For a patient HIV positive, of course, we have to try to eradicate the hepatitis C. The criteria for treatment initiations are progressive or symptomatic splenomegaly and or any progressive cytopenia in terms of anemia with an hemoglobin less than 10, platelets less than 80,000, or the neutrophil less than 1,000. Treatment modalities, splenectomy is could be interesting in selected cases where rituximab is not indicated or ineffective. Rituximab monotherapy, 4/8 weekly doses, rapidly active, and the overall response rate in the majority of these cases is 80%, with a CR roughly 40%. The 10 years progression-free survival is more than 80%. Rituximab monotherapy could be the preferred initial treatment, and there are no prospective study at this point. There is an off-label in Italy concerning the activity and the use of rituximab. Chemoimmunotherapy, when rituximab single agent is ineffective, is when we have a disseminated disease and sign of histological transformation. Of course, chemoimmunotherapy is the standard treatment. The role of splenectomy in splenic marginal zone lymphoma, the 5-year progression-free survival is ranged between 50 to 60% according to the publication, and the 5-year survival is close to 80%. The pros are definitive histological diagnosis, no further therapy in at least 50% of the cases. The cons are major surgical procedure with acute and sometimes late complication, is not curative because there is a bone marrow infiltration, the lymph node presence, and at the same time, You can have bleeding, infection by encapsulated bacteria with 5% overall toxic deaths. These are the data, the public data with the authors, the number of the patient, the overall response rate, the progression-free survival, the overall survival, the toxic deaths. You can see here that at the end of the day, the data are quite interesting in terms of overall response rate and also in terms of progression and overall survival at more than 5 years. Really few cases of toxic deaths. The role of rituximab monotherapy, there are some retrospective study, and this was the most important with 108 patients published by Kalpadakis and co-workers on blood in 2018. And the rituximab was monotherapy for 6 weekly courses. From the responding patient who obtained at least a partial response, there was maintained treatment for 1 or 2 years at physician discretion. After the induction, the CR rate was 44%, and the overall response rate was more than 90%. 78 patients out of 100 patients underwent to maintain treatment with rituximab, and 14 patients had a conversion from PR to CR. Only 9 deaths were observed, 4 of them because of progression of the disease. The median follow-up was 57 months, and you can see here the failure of progression. There is an advantage when you compare maintained treatment versus only observations. There is no difference at the same time when you compare the 2 different periods of treatment with rituximab, 1 year of 2 years. And another important study was the BRISMA from the Italian cooperative study group, in conjunction with the International Extranodal Lymphoma Study Group. The study was the number 36, BR as a frontline treatment for splenic marginal zone lymphoma. We included 56 patients, all symptomatic, and the diagnosis was prospectively confirmed. At the end of the day, there were more than 1/3 of the patients with high risk, according to the prognostic score. The CR rate was 73%, the overall response rate was 91%, and the progression-free survival 3 years was 90%, with a median follow-up of 32 months, and the overall survival 3 years was close to 100%. The 3-year event-free survival were 80%. The 3-year duration response was 93%. So at the end of the day, it seems active in symptomatic patients, BR also in splenic marginal zone lymphoma. And the last histological subtype inside the marginal zone lymphoma is the primary nodal marginal zone lymphoma. Is a monocytoid B-cell lymphoma. The median age of this patient is from 40 to 64 years. Usually there are no B symptoms with a good performance status. The presentation is disseminated lymph node with no bulky disease, and the bone marrow infiltration is observed in 30% of the patients. It's very important to require the exclusion of splenic and margin and extranodal marginal lymphoma, and there is a distinct molecular pathogenesis. You can observe here the data, including Notch H2 and also KLF2. The treatment, according to the ESMO guideline, is quite similar to follicular lymphoma, including chemoimmunotherapy such as bendamustine plus rituximab, CHOP plus rituximab, or COP or CVP plus rituximab. There is an interesting study called NF10. We did this kind of study in Italy, was published by Luminari and Merli on Blood 2019 to evaluate the early progression called POD24 in marginal zone lymphoma. We included 321 patients with marginal zone lymphoma treated within 3 months from diagnosis, and the majority of these patients were treated with conventional chemoimmunotherapy, and there were 90 progression-free survival events, and the 5-year progression-free survival was 64%. And you can see here in terms of overall survival, the blue curve included POD24 that the children and the patient there were no POD24, and the POD24 positive area where the yellow curves. There is a very important difference in terms of 3 overall survival between the POD24 they obtain a response versus patient did obtain a response. In terms of number of events, in terms of transformation, marginal zone lymphoma, we observed only 7 patients. All these patients were POD24. And the rate of POD24 for the patient for the response were 18%, and in particular, the POD24 were 19.5 times increased the risk of death, and you can see here the real difference in terms of overall survival, roughly 90% versus a range between 37 to 67%. The POD24 in the marginal zone subtype, you can see observe in extranodal marginal zone, in splenic, in nodal, in disseminated marginal zone lymphoma, and you can see a real, again, the disadvantage for patients who present the POD24 situation in all these different histological subtypes. Is there a role for autostem cell transplant in marginal zone lymphoma? These are the data by a BMT study published by Avivi and co-workers on British Journal Hematology on 2018. There was a retrospective ABMT field and GITMO study, including 199 non-transformed marginal zone lymphoma, including in the majority extranodal marginal lymphoma, but also 55 patients with nodal and 33 patients with splenic marginal zone lymphoma. The median age at autostem cell transplant was 56, ranging between 48 to 60, and the majority of the patients had 2 median prior line of treatment, including rituximab in 2/3 of the patients. In the median time from marginal zone lymphoma to diagnosis to autostem cell was 2 years. 95% of the patients were considered chemosensitive at the time of the autostem cell transplant. In terms of 5-year non-related mortality was 9%, and also the second primary malignancy was observed in only 6% of the patients. The event-free survival was 53% at 5 years. The overall survival at 5 years was 73%. There was a huge difference in terms of overall survival when you compare a young patient versus old patient, and at the same time, the cumulative incidence of relapse was close to 40%, and the overall survival also, when you compare the mal lymphoma versus splenic, the extranodal mal lymphoma versus the splenic one was quite different in advantage of the extranodal marginal mal lymphoma. There are also some novel drugs for the treatment of relapsed refractory marginal zone lymphoma. The classes are PI3K inhibitor, the BTK inhibitors, also really few data concerning lenalidomide. Inside the PI3K inhibitor, one of the most active was considered umbralisib. The umbralisib obtained the FDA official indication for the treatment of relapsed refractory marginal zone lymphoma, but a few months ago, because of the toxicity. FDA withdrawn umbralisib in June 2020 for the official indication of follicular lymphoma, but also marginal zone lymphoma. You can see here for umbralisib, the data were quite interesting because the overall survival was 46%, 49%, and the CR rate was close to 15-16%. At the same time, among the BTK inhibitors, there are ibrutinib, where the activity in terms of overall response rate is close to 50%, and the CR rate is no more than 10%, and zanubrutinib, according to the phase 2 Magnolia study, the overall response rate was 68%, and the CR rate was more than 25%. Both of them, ibrutinib and zanubrutinib, have the FDA official approval for this setting of patient. In particular, also in Italy, you have a specific rule called 6A48, and we can use ibrutinib so far. As I said before, the data of lenalidomide plus rituximab, there was a publication including 74 patients. The overall response rate was 68% with the median duration response of roughly 40 months. These are the data of ibrutinib in the phase 2 study conducted by Noy and co-workers from the Dana-Farber. This was the first publication, Blood 2017, 63 patients, all the 3 different histology are represented, and the median time to response was roughly 5 months. And you can see here that the overall response rate is roughly 50%, but at the same time, the CR rate is a range between 3 to 7%. The median progression-free survival is 14.2 months, and the median overall survival was not reached. There was an update of this phase 2 study published again by Noy and co-workers on Blood Evidence Advance 2 years ago. And you can see here that the median progression-free survival was close to 16 months. And again, the median overall survival was not reached, and 72% at 33 months. The median progression-free survival was better if only prior rituximab was used versus patient pretreated with rituximab and chemotherapy. At the same time, according to the phase 2 Magnolia study, was involved in this trial. We included 68 patients. Also in this situation, all the 3 histological subtypes are represented. We used the classical dose of zanubrutinib, 160 milligram BID. And the median follow-up was close to 16 months. And the overall response rate, according to the center review, that was quite similar to the investigator assessment, was 26% of CR rate, and the overall response rate was close to 69%. The progression-free survival was roughly 83% at 1 year and 15 months, and the duration response was 93% at 1 year. This data were recently published by Orpat and co-workers. In terms of BTK inhibitor toxicity, when you compare ibrutinib and zanubrutinib, you know very well that the second generation, I mean, zanubrutinib is less toxic in terms of side effects of best interest, and in particular, atrial fibrillation, only grade 3 and 4, only 1.5% versus 8% for ibrutinib, and major hemorrhage was not observed in Zanu study, was in 3% in the ibrutinib phase 2 study. At the same time, also the infection grade 3 and 4 was 22% in the ibrutinib study versus 16% in the zanubrutinib study. In terms of a new study, there is the Malibu study. According to the study is the International Extraordinary Lymphoma Study Group 47. The schema is ibrutinib plus rituximab in frontline treatment for marginal zone lymphoma. including all the 3 different histological subtypes, the adult lymphoma, the nodal, and also the splenic. The study is ongoing, and the primary endpoint are the complete response rate at 1 year, the progression-free survival at 5 years. There are two different parts of the induction, part 8 and part B, and then there is a maintained treatment using this kind of combination, ibrutinib plus rituximab, moving in frontline treatment. These are the data concerning the role of another PI3K inhibitor, idelalisib, in the double refractory marginal lymphoma. Really few patients, 15. The overall response rate was 47%. The CR rate was observed in 7% of the patients. These are the data, as I said before, of Umbralisib. This was with this data, there was the final official indication by FDA. And the overall response rate was close to 50%. In particular, the complete response was 16%. And the median follow-up was close to 88 months. And in particular, in terms of duration response, all the patients who obtain a complete metabolic response are in continuous complete response. The progression-free survival 2 years is roughly 50%. The real problem in this case, in terms of safety profile, is the specific and peculiar PI3K toxicity related to diarrhea grade 3 and 4 in 3% of the patient, transaminitis grade 3 and 4% in at least 4% of the patient. No cases of grade 3 and 4 pneumonitis were observed in this study. The data concerning the role of this combination of rituximab plus lenalidomide R² in relapsed refractory marginal zone lymphoma. There was the AUME study, a phase 3 study comparing rituximab versus R². In this case, the majority of the patients are follicular lymphoma, but they included also 63 patients. They progressed with multiple lymphoma, and nodal and splenic marginal zone lymphoma. Progression-free survival advantage for the whole cohort was observed, I mean, in follicular lymphoma, but not in marginal zone lymphoma, according to the publication by Leonard and co-workers on JCO 2019. At the same time, the Manifest study by Coleman and co-workers presented at ASH meeting also recently at the last EHA meeting was a phase 3 randomized study comparing R² induction in relapsed refractory follicular marginal zone lymphoma, and then there was a randomization in terms of maintenance treatment with R² versus maintenance treatment with rituximab. And in this case, you can see here for the marginal zone lymphoma where there were 74 patients. The overall response rate for all this study population was 68%. The CR rate was close to 40%, and the median duration response was close to 39 months. There are also some data concerning the role of CAR T-cell. In this case, the product is axi-cell in the SURZUMA-5 study. Jacobson and co-workers presented at ASH meeting 2 years ago, but also now in the ZUMA-5 there are also follicular lymphoma. There was official indication by FDA for the follicular lymphoma subset, but not yet for marginal zone lymphoma. They included only 22 patients with marginal zone lymphoma, representing all the 3 different histological subtypes. 50% of the patients were POD24. The median number of prior treatment was 3, ranging between 2 to 8. And you can see here the impressive result in terms of clinical response, 85% overall response rate for marginal zone lymphoma, and the CR rate was 60%. Grade 3 and 4 CRS was 79% of the patient. Grade 3 and 4 ICAS was observed only in 1 case with grade 5. The median duration response was quite interesting for follicular lymphoma, and for the marginal zone lymphoma, the median duration response was 11 months. The progression-free survival was close to 12 months. And now we are waiting for a longer follow-up to really understand if it's possible to consider also CAR T-cell in marginal zone lymphoma for the official indication by FDA and also for EMA. Another important point concerning the marginal zone lymphoma is the histological transformation. This paper by Alderuccio and co-workers published by the Miami group on JCO 2018. They included more than 440 patients. The majority were extranodal lymphoma, but also there are a few patients with nodal and splenic marginal zone lymphoma. The cumulative histological transformation index was calculated at 5 years in 6.6%, at 10 years in 8.4%. The high histological transformation risk were the patient who did obtain a complete response, the high LDH level, and patient who presented more than 4 nodal sites at diagnosis. You can see here the real difference in terms of overall survival between patients with histological transformation versus patients without histological transformation. Another important point, as I said at the beginning, is the pathogenesis, hepatitis C correlation association with marginal zone lymphoma. And this was a study. There are several studies, including this kind of patients. And you can see here this distribution of HIV-related patient with marginal zone lymphoma in the different sites. The most frequent are skin, salivary glands, and ocular nexa. And the percentage in other publication of small marginal zone lymphoma, hepatitis C positive, was observed in 19% by Arcaini co-workers. In multi-lymphoma, 34%, again, by Arcaini co-workers. In Italy, we did a trial. The FIELD-BART was the first prospective study using antiviral treatment in indolent non-Hodgkin patient hepatitis C positive. Was a phase 2 multi-center study, including follicular lymphoma, but also some patients with the marginal zone lymphoma. And these are the different kind of treatment on antiviral with evaluation of the sustained virological response. This was the primary endpoint. The second endpoint were overall survival and progression-free survival. You can see here the preliminary data in terms of virological response was quite high, more than 90%, and the lymphoma response, according to the different histological subtype, in particular for marginal zone lymphoma, the overall response rate was observed in at least 50% of the patients, and 26 of them obtained a complete metabolic response with this kind of virological treatment. And in terms of progression-free survival of the FIELD-BART, the 3-year progression-free survival is 80% with a median follow-up of roughly 33 months. There were no deaths, and in fact the overall survival is 100%. And there are no difference in the progression-free survival between marginal zone lymphoma versus non-marginal zone lymphoma or among histological subtypes. In conclusion, distinct marginal zone lymphoma subtype with specific genetic lesion and mutational landscape. These are very important to establish these 3 different histological subtypes. There is an antigen-driven process with response to antibiotic or to antiviral, as we see in the last few slides, according to the activity of the antiviral in hepatitis C positive. Prognosis generally good, but highly heterogeneous. The 2 main molecular clusters and the 2 microenvironment classes in splenic and marginal zone lymphoma were extrapolated by the International Extranodal Lymphoma Study Group 46. And there is the early progression, I mean, POD24 is associated with markedly low overall survival. There is an excellent response to conventional immunochemotherapy like bendamustine plus rituximab in advanced stage marginal zone lymphoma. Novel agents are extremely promising, especially BTK inhibitors such as brutinib and zanubrutinib approved by FDA. There was also PI3K inhibitor, but now is excluded by the FDA a few months ago. And this kind of molecules are moving towards the front line. Phase 2 and phase 3 study with novel agent being selectively planned in relapsed refractory marginal zone lymphoma, and phase 3 study are being planned in front line like the International Extranodal Lymphoma Study Group 48, comparing BTK plus rituximab versus rituximab as a single agent. Thank you very much for your attention.
Thank you, sir. Dr. Zinjani, that was a wonderful talk. Learned a lot. So we have some of our colleagues from here who may like to ask you some questions. If any one of you have any question, please use raise hand sign, open your videos and go ahead. Dr. Shekhar Patil, please. Yes. You are muted.
With the present so much of novel agents, chemotherapy, chemoimmunotherapy, such good results in splenic marginal lymphoma, when we should order for a splenectomy, when we should generally look for doing a splenectomy rather than using the drugs what we are having it now. Indications for splenectomy at the upfront.
The indication of splenectomy, as I said before, if you have a very important splenomegaly, and it depends by the level of hemoglobin, platelets, and also neutrophils. And normally in our hands, in my institution, we use splenectomy in 2-3 cases per year, and the data also, as I showed before, are really interesting in terms of overall survival, progression-free survival with a risk of death less than 5%. I mean, in this case, in particular, when you have a huge splenomegaly, it could be really difficult to start with the treatment because in this case, patients present a very low number of platelets, often is less than 50,000, and also low level of hemoglobin less than 8 grams per deciliter.
Thank you, sir. The second question is regarding the role of transplant. If the patient has got a progression within, we have got few patients within 24 months, should we subject them, they are otherwise fit for transplant, or go for some novel agents like BTK inhibitors or lenalidomide like that?
Yeah, the data concerning the potential role of autostem cell transplant in marginal zone lymphoma is overall in the histological subtype of nodal marginal zone lymphoma. That it seems more aggressive when there is a progression of relapse after the front line, and could be indicated in young patients with a good performance status. Of course, first of all, before to move to the consolidation, you need to obtain a complete metabolic response. This could be quite difficult. With the advent of CAR-T, but we are waiting for the final potential official indication according to the ZUMA-5, also for marginal zone lymphoma. We are very hopeful to use the bispecific monoclonal antibody. As you know, bispecific monoclonal antibody are really active in relapsed refractory follicular lymphoma, diffuse B-cell lymphoma. There are a few data also in mantle cell lymphoma. Now they will start few studies concerning the role of this bispecific also in marginal zone lymphoma. That could be a very important therapeutic approach for the future for our patients.
Thank you, sir. Thank you very much.
Thank you. Dr. Priyanka?
Thank you, sir, for that wonderful talk. We have a case actually. He's a 30-year-old male presented with splenic marginal zone lymphoma, diagnosed 1.5 years back. now presented again with anemia and symptomatic splenomegaly. This time we again did a marrow, but CD20 is not expressed. He got rituximab 4 doses earlier weekly, and he was able to complete response, hematological response, and the spleen was also good. We did a CECT then. But this time again, when he has relapsed, the CD20 expression is not there. So after now, if we treat, would it be wiser to go with a monoclonal antibody rituximab or to move with proton kinase inhibitors?
Now, the best way in this case, considering the therapeutic story of this patient, could be to use a BTK inhibitor, such as ibrutinib or zanubrutinib, if it's possible. It depends by the bureaucratic situation in your country concerning the potential use of these two BTK inhibitors.
And sir, how long to use? It will be lifelong because he's a young patient.
I mean, the situation concerning the duration of the treatment for BTK in marginal zone lymphoma is absolutely the same that normally used for CLL and mantle cell lymphoma. I mean, until the progression. In both trials, the published by Noy for the rituximab and the Magnolia study published by OPAT, the study schema was until the progression.
We are run out of time. Dr. Arihant, one quick last question. Arihant, you have a question?
Yeah. Yes, sir. Am I audible?
Yeah.
So this is regarding ocular adnexal MZL. So my question is regarding to radiotherapy, intralesional rituximab versus systemic rituximab. That is the question, and your preference.
Yeah, if there is a positivity of chlamydia, molecular positivity, first of all, you can try the antibiotic treatment, like, for example, for Helicobacter pylori in the gastric multi-lymphoma, you have to use clarithromycin, and is active in at least 50–60% of the patient. If there is a fail after this antibiotic treatment, or is negative for the chlamydia, first of all, you can use rituximab for weekly administration, rituximab plus eventually other for a weekly administration. I don't like to use local radiotherapy because it could be quite toxic according to the site of the lymphoma close to the eye.
Thank you, sir. I'm extremely grateful to you for sparing your time, joining us and educating us.
Thank you very much. Bye-bye.
Bye-bye, sir. Thank you.
Have a good night. Bye-bye.
So we have the last lecture of the day now. Dr. Mehdi Hamadani from USA is our next guest speaker. He's going to speak to us on double refractory Hodgkin lymphoma, tackling relapse after brentuximab vedotin and checkpoint inhibitors. He's Professor of Medicine, Director BMT and Cellular Therapy Program, Scientific Director CIBMTR, Division of Hematology and Oncology, Medical College of Wisconsin, Milwaukee. He's Professor of Internal Medicine at the Medical College of Wisconsin, Division of Hematology and Oncology, specializing in lymphoma and bone marrow transplants. He serves as the Director of the Adult Blood and Marrow Transplant Program at Wisconsin. He completed residency in internal medicine at Oklahoma University Health Sciences Center, followed by fellowship in hematology oncology at the Ohio State University. During his fellowship, he received the James Warren Award for accomplishments as the most outstanding research fellow. Before joining the Medical College of Wisconsin, he served as an associate professor of medicine and director of myeloma and lymphoma program at West Virginia University. I invite him to give his talk on double refractory Hodgkin lymphoma, tackling relapse after BV and checkpoint inhibitors.
Hi, Dr. Mohan. So I hope you can hear me okay?
Yes.
Okay, so thank you so much for your kind invite. And I didn't realize that the talk is going to overlap with the Asia Cup final, right? So that's hopefully going well in the background. So I'm gonna quickly share my screen. If you guys don't see it in a slide presentation mode, please let me know. So hopefully this should be in a full screen now.
Yes, sir. Yes.
Okay, perfect. So today I would try to wrap this up in maybe 35 to 40 minutes. So we're gonna talk about how we would approach a classical Hodgkin lymphoma patients that has failed both brentuximab vedotin and a checkpoint inhibitor. These are my disclosures to this talk. So very relevant for this talk is going to be my consultancy for ADCT therapeutics, as well as some cell therapy companies. So I'm going to kick off this talk with a patient of mine. He was a very healthy, or is a very healthy 32-year-old gentleman with classical Hodgkin lymphoma. In frontline at an outside institution, the patient was treated for stage 4 Hodgkin lymphoma with essentially 6 cycles of ABVD using a Rathel-like approach. So in response to frontline therapy, the patient achieved a complete PET negative response, but he relapsed within 1 year of achieving remission. At relapse, his disease recurrence was confirmed with a biopsy. So as you know, 1 year therapy failure is a high-risk factor for Hodgkin lymphoma. So in second line, in a community hospital, he was treated with 2 cycles of ice. He had refractory disease. At that point, he was referred to our center. So we recommended third line treatment with a combination of brentuximab vedotin and nivolumab. Off trial, patient achieved a second PET negative remission with this regimen, and we consolidated him with high dose therapy and autologous transplant. And since he had high risk disease, he was placed on brentuximab vedotin consolidation. And while the patient was on brentuximab vedotin, he had again a biopsy confirmed relapse of this disease. So he's clearly brentuximab vedotin refractory. So for failure, patient was placed on nivolumab. Patient had a partial remission to pembrolizumab, and he stayed in partial remission for approximately 18 months, and then he had clear progression of disease. So the question is, what are we going to do with this patient who has clearly failed brentuximab vedotin and pembrolizumab? So one concept to keep in mind is that we are moving sometimes to a strategy where patients who have been in sustained PET negative remissions with checkpoint inhibitors, you can give them drug holidays. And if these patients relapse further down the road, they are not necessarily checkpoint inhibitor failures. You can re-challenge those patients with a checkpoint inhibitor, and same argument can be extended to brentuximab vedotin. So I wanted to keep this case simple. This case is a no-brainer. He has clearly failed BV. He has clearly failed a checkpoint inhibitor. At least in my practice, I wouldn't challenge this patient with either of these agents again. So how would we approach this case in 2022? So in such circumstances, I think it's always a good time as a clinician to have a shared decision-making with your patient to stop and reassess your treatment goals in a sense. Now, I would acknowledge that most of Hodgkin patients are young patients. Even with relapsed refractory disease, the median age of these patients is usually late 30s. So cure or curative therapies remain our goal for these patients. So when you're thinking about curative therapy, you have to think about, what therapy would achieve that goal, and you have to think about strategies to control their disease to achieve that curative goal. But occasionally you do see patients who are old, frail, or unfit. And in those patients, I think when you discuss long-term treatment goals, sometimes palliative approach should be kept in mind. Now, I would acknowledge that when we think about double refractory patients, it was uncommon in the past, but in the modern era, it's not uncommon to see a patient who has double refractory disease who are relatively chemotherapy naive. So I'm going to start with a case of think of a older unfit patient who has failed both of these agents, how would you approach these cases? So in such cases, keep the option of consolidative radiation therapy in mind, especially an older unfit patient who has relapsed disease in a couple of foci. Sometimes radiation can really buy you a lot of disease control for an extended period of time. So it's not, it's old-fashioned, but it's useful. And then in such older unfit patients, you can sequence single agents. Vinblastine as a single agent has activity, navalbine as single agent has activity, bendamustine can provide you temporary responses. So for palliative purposes, there's a number of options out there. Doxil as a single agent has very nice activity in Hodgkin's. But if you're thinking about a typically young patient who can tolerate multi-agent chemotherapy, then you can think about a chemotherapy regimen that patient may not have been exposed to in the past. So the case I was presenting, you can theoretically salvage that patient with a gemcitabine-based regimen. Gemcitabine is very active in patients with Hodgkin lymphoma, and regimens where gemcitabine is combined with a platinum or navalbine and doxil, the so-called GVD regimen. They're active regimens, and they continue to have some place in the management of these double refractory patients. Similarly, if some patient has seen gemcitabine in the past, but they have never seen platinums, agents like ICE, DHAP, ESHAP, they can give you at least a temporary response where you can use that response to bridge those patients to more definitive therapies. Now, let's switch gears a little bit and think about more experimental approaches for double refractory patients that are in development. So one relevant pathway is CD25. Now, all of you are obviously familiar with brentuximab vedotin, which targets CD30 on the surface of Hodgkin lymphomas. So there is a drug in development called camidenlimab tesirine, where our group has done a lot of work with this agent in phase 1 and phase 2 setting. So camidenlimab is a CD25 drug antibody conjugate, and the payload on this antibody is a toxin called PPD, or pyrrolobenzodiazepine. And what happens with camidenlimab is cami binds to CD25 on the surface of the tumor cells. It is internalized, and then it releases the PPD toxin, which is a potent alkylator. It causes DNA interstrand crosslinks that subsequently leads to cell death. Now, the neat concept here is that Hodgkin lymphoma cells do express CD25, but the expression is not as consistent as CD30 expression. So it is entirely possible that this drug works by maybe not targeting the Reed-Sternberg cells, but maybe targeting the T cells that rosette Reed-Sternberg cells, and these T cells provide survival signals to Hodgkin lymphoma cells, and maybe this drug exerts cytotoxicity indirectly. But whatever is the true mechanism of action, when we tested this drug in phase 1 trial, the drug has had remarkable activity in Hodgkin lymphoma with response rates, at least in the phase 1 setting, approaching about 70 to 80%. And the drug has a very interesting toxicity profile that would cover in the coming few slides. So when this very encouraging signal of toxicity was seen, or efficacy was seen in the phase 1 study, that led to a recently concluded phase 2 study, which was dedicated to patients with classical Hodgkin lymphoma. So this trial finished accrual late last year. And this study was using single-agent camidenlimab tesirine in patients with relapsed refractory classical Hodgkin lymphoma. The drug is a simple IV infusion. You give it every 3 weeks. And the way the drug is dosed is you give 2 doses of 45 microgram per kilogram in cycle 1 and cycle 2. And from cycle 3 onwards, you reduce the dose to 30 microgram per kilogram based on pharmacokinetic data. And you continue the drug until progression and tolerability, or up to a period of maximum of 1 year. So as of November 2021, 117 patients were enrolled on this phase 2 trial. The eligibility criteria, it was enrolling adult Hodgkin lymphoma patients who needed to have at least 3 prior lines of therapy. And if they were transplant ineligible, at least 2 prior lines of therapy. And these patients must have been treated with BV and a checkpoint inhibitor in the past. So exactly the scenario that we are talking about today. The trial is specifically excluded patients with history of autoimmune neuropathies because of the toxicity profile of this drug, as well as patients with history of significant third space fluid accumulations like anasarca, ascites, again, because of the toxicity profile of this drug. So in the phase 2 study, the drug was again active, response rates exceeding 70%. Half of the responses are complete remission, half are partial remission. Whether the patients had a prior oro transplant or not, the drug was active. In patients with prior transplant, the overall response rates were 74%. The patients with no prior transplant, the response rates were about 63%. It kind of makes sense. Remember, patients who get to transplant inherently at some point must have had chemosensitive disease, maybe better disease biology. Maybe that's why this drug works better in patients with history of prior transplant. But even in patients with more refractory disease who never get to an oro transplant, the drug is still fairly active. Now, the responses appear to be relatively durable. If you achieve a complete response, the duration of response is 14 months, a little over a year. In all comers, CRs and PRs combined, the duration of response is about 13 months. And the responses are achieved relatively quickly. So after 2 cycles, the median time to complete response was about 41 days. Now, this toxin on this drug, the pyrrolobenzodiazepine, you may be familiar with this toxin because the same toxin is added on to loncastuximab tesirine, the CD19-directed drug antibody conjugate that is approved in patients with relapsed refractory diffuse large B-cell lymphoma, same immunotoxin and same toxicity. So if you ever use lonca causes a rash, AST, ALT elevation, gamma GGT elevation, and edema and effusion, and this drug has the same toxicity signal. So that's why the eligibility criteria required patients with significant fluid accumulation not to come on the drug. Now, the most interesting and concerning toxicity of this drug is the development of Guillain-Barré syndrome. So both in the phase 1 setting as well as in the phase 2 setting, about 6% of the patients who are exposed to this drug do develop Guillain-Barré syndrome or syndrome of polyneuropathy. Now, this is a troubling toxicity. This is a very active drug, but with a toxicity profile that cannot be ignored. So if this drug will get FDA approval down the road, I think our better understanding of patients who are at risk of developing this toxicity is going to be key in determining the clinical use of this drug. Now, Chemi is obviously not the only drug being explored in this double refractory setting. So as you know, mTOR inhibitors have single agent activity in patients with classical Hodgkin lymphoma. And similarly, JAK-STAT pathway is also active in patients with relapsed refractory Hodgkin lymphoma. In fact, JAK-STAT pathway upregulations are known in patients with checkpoint inhibitor refractory disease. So the group at University of Pennsylvania, led by Dr. Swoboda, looked at a combination of combining an mTOR inhibitor called everolimus with a JAK1 inhibitor called itacitinib in patients with relapsed refractory classical Hodgkin lymphoma who were either failing or not tolerating either brentuximab vedotin or a checkpoint inhibitor. So this was a small study reported at the last American Society of Hematology meeting. They enrolled 16 patients. The drug is fairly active. Response rates are around 75%. Most of the patients do not achieve a complete response. Most responses are partial responses, and the responses hang around for about 9 months. So it's not an FDA-approved combination. This is obviously an ongoing trial with early results from 16 patients, but they do certainly look very interesting. Now, moving on, the next concept is when patients fail checkpoint inhibitor, what process is driving that checkpoint inhibitor refractoriness? And I'm not aware of any Hodgkin lymphoma specific data that tells us why patients become refractory to these immune checkpoint inhibitors. But there is obviously a wealth of data from solid tumors, mostly melanoma and renal cell carcinoma, where there are certain relevant pathways that may be exploitable in approaching a case with checkpoint inhibitor refractory disease. So at least in solid tumors, some of the PD-1 resistance is mediated by alterations in the JAK1 and JAK2 pathways. A second possible mechanism is downregulation of MHC class 1 molecules, which is also called beta-2 microglobulins through mutations. So remember, if you downregulate your MHC molecule, you sort of hide yourself from immune surveillance. So that's a way of evading the immune system. And at least in solid tumors, there are data that when these tumor cells are becoming resistant to checkpoint inhibitors, it may be mediated by upregulation of other alternative immune checkpoints like the TIM3 pathway or the TIGIT pathway or LAG3 pathway and VISTA. And there are drugs that are under development, specifically in Hodgkin lymphoma, that target this pathway. In the interest of time, I'm going to show you maybe one or two examples, but I would refer you to a drug called feviziluzumab, which is a LAG3 inhibitor that has been tested in patients with classical Hodgkin lymphoma that have failed a checkpoint inhibitor, and response rates to Favi in that setting are about 30-35%. Sanofi has a TIGIT inhibitor that trial just finished accrual both in patients with PD-1 naive disease as well as PD-1 refractory disease. None of the data from that trial have been published, but it would be very exciting to see those results when they're available. One strategy with more data, I just mentioned that PD-1 resistance may be mediated by alterations in JAK1 and JAK2 pathway. So the Big 10 group in Midwest, led by Dr. Veronika Bakanova, led a phase 1, phase 2 study that looked at a combination of nivolumab plus ruxolitinib, which is a JAK1, JAK2 inhibitor in patients with PD-1 refractory disease. So preliminary results of that trial were presented at the last American Society of Hematology meeting, where they reported results on 17 subjects. All of these patients had failed a checkpoint inhibitor in the past. So in these patients, the checkpoint inhibitor was combined with ruxolitinib, a JAK1, JAK2 inhibitor, and they report favorable responses of about 48% in these patients. They count stable disease or immunological response in their response category, but if you look at traditional CR and complete remissions or partial remissions, the rates are about 36%. One possible criticism of the study is if you look at the Jakafi single agent study in classical Hodgkin lymphoma, the response rates with single agent Jakafi are in the 30% ballpark. So if you're really analyzing this data under a microscope, you may say that the activity on this trial may solely be coming from a JAK inhibitor, but certainly it's an exciting approach, and final results of these trials are going to be important. So I hope I have made a case that while double refractory classical Hodgkin lymphoma is an area of unmet need, there are certain strategies available, not only using traditional chemotherapies or radiation therapy, where you can achieve a response, but there are obviously novel strategies in development, like targeting the CD25 drug antibody or CD25 pathway using chemi, or these novel approaches of combining a JAK inhibitor with either an mTOR inhibitor or resensitizing PD-1 failures. So the concept is, if you can achieve a remission in a double refractory patients, are these therapies necessarily curative? And the answer is no. There is no data that these treatments are going to be cures. So what are you going to do with these patients? So the example of the patient I showed in the beginning, the patient was referred to my center to participate in the trial with camidenlumab, the CD25 drug antibody conjugate. So I treated the patient with cami. This patient was using cami in 6th line setting. And you can see that after 4 cycles of cami, the patient had a beautiful complete remission. Now, this is a 32-year-old patient. I don't think cami cures Hodgkin lymphoma patients, at least not the vast majority of those patients. So question becomes, what are we going to do with this patient? Are we going to keep this patient on this agent and hope for the best? Or can we consolidate this patient with a definitive approach? And one such approach over the years obviously have been an allogenic stem cell transplant from either a matched donor or in more recent year, alternative donors. So is in year 2022, is allogenic transplant still a viable modality? And this is a strategy, I think, which does have, at least in non-transplant centers, a bad reputation. And transplant is, for those of you in the audience who do transplant, it's a very center-specific modality. So you have to keep the center experience in mind. But if you look at the classical data of allogenic transplant outcomes in patients with classical Hodgkin lymphoma, the outcomes were concerning. So this is a classical paper by Anna Soreda using the European registry data. And these data came out more than, I guess, 14 years ago. And it shows that even with reduced intensity approaches, that risk of treatment-related mortality at 1 year was about 23%. It was almost 50% with myeloablative approaches. So the procedure-related mortality with low-intensity transplants was 25%, with high-intensity transplants was 50%. And the 3-year survival was dismal. It was best-case scenario, 35%. So you have to keep these numbers from a historical perspective in mind, and that sort of like clouds the judgment of a lot of people when they think about allotransplant, because they keep referring to these older data. But and that's sort of what probably reflects in, at least in the US practice. So these are the numbers of allotransplants done in Hodgkin lymphoma over the last 15 years, and you can see that overall, these numbers largely have been declining, and part of the reason is approval of brentuximab vedotin, as well as checkpoint inhibitors over the years, which rightly have led to decline in the use of this transplant procedure. But I work for CIBMTR, which is a large international transplant registry. So recently, with one of my mid-career faculties, Dr. Neerav Shah, we queried the database to see how survival outcomes of allogenic transplant and Hodgkin lymphoma are doing. And if you can see in this curve, the long-term survival has gradually improved over the years. If you look at the 1990 to 95 era, that is the bottom blue line, the 5-year survival was sitting at around 20%, and the top line is 2016 to 2020. So things over the years have consecutively gotten better, which led to our group asking the question, what is driving this improved outcomes? So Sarah Ahmad at University of MD Anderson Cancer Center led a study in collaboration with our group where we looked at modern reduced intensity transplant platforms. So we wanted to get rid of all the toxic regimens that should never be used in lymphoma patients, the Flubuphors of the world or Bucy's of the world. So we looked at modern reduced intensity conditioning regimens, and we asked the question, what is the modern non-relapse mortality or treatment-related mortality of these patients? And remember, Anna Sureda's paper in 2008, which looked at data from 1990s predominantly, reported a 1-year non-relapse mortality of around 30%. That number is now 10% or below in the modern era. And the 4-year survival is almost twice as high as the 3-year survival in the prior European experience. So the question is, what is driving this outcome? Is probably wider use of reduced intensity regimens, probably better supportive care. And our data is not an outlier. If you look at the more modern data from EBMT, you can see that their 2-year survivals are very similar to the CIBMTR paper I mentioned. So overall, transplant is becoming a safer, more viable platform for patients with Hodgkin lymphoma. So I think we have done a good job of controlling transplant-related mortality. We have brought it down from maybe 30% down to 10% or below. And in my opinion, in the recent past, I'm not talking about current era, I'm talking about maybe in the era of 2005 through maybe 2015, 16, the biggest challenge with transplant was the transplant-related mortality wasn't very high, but the relapse rates was the problem. We transplanted Hodgkin lymphoma patients and the disease would come back. So if you look at the CIBMTR experience I just shared, in our experience from 2008 through 2016, the most common reason transplant was failing was because patients were relapsing. And the relapse rates are super high. So if you look at the 4-year relapse rate, the 4-year relapse rate on our analysis was about best case scenario 50%, right? So keep this 50% relapse rate figure in mind because of some changes, I think that has been changing. So one of the questions that we next asked was, okay, if the relapse rate is high, can we capitalize on HLA disparities to improve transplant outcomes? Because there is a bias in the field is that if you do a haploidentical transplant in patients with Hodgkin lymphoma, maybe that is the way to go. And I'm skeptical of that finding. So again, Saira Ahmed from MD Anderson collaborated with our group where we looked at transplant outcomes of matched HLA matched sibling, which is arguably the gold standard donor source, and haploidentical donors. It was a large study of around 600 plus patients, and a third of about 20% of patients on this study shown in this box had refractory disease coming into transplant. Now, if you look at survival outcomes, on the left curve, the overall survival of matched related or haploidentical transplants are identical. It shows that haploidentical donors are reasonable donor source. There's no question about it, but it's not necessarily better than an HLA identical transplant. And I would again point out that in this modern era study, the rate of relapses are again very low. 1-year non-relapse mortality with HLA identical related donor is just 6%. Now, does haploidentical transplant mitigate the risk of relapse? You can look at the p-value here. It's not significant, but there is a trend that maybe haploidentical donors may be associated with a lower risk of relapse. But again, with haploidentical donors, half of the patients in this 2008 through 2016 study were still relapsing. And I know most of these patients coming into our database had not seen a checkpoint inhibitor by the time they got to a transplant. Some did, but most didn't. And I point that out because the patients that we transplant in 2020 are very different from patients I was even transplanting 7 or 8 years ago, because most of these patients now, Hodgkin lymphoma patients, when they get to transplant, a vast majority, not everybody, have had checkpoint inhibitor exposure in the peri-transplant period. And you are familiar with findings from the Dana-Farber group shown on the left side, that if you have checkpoint inhibitor exposure before transplant, these patients are at a ultra high risk of developing either a febrile immune hepatitis-like syndrome, or they have a very high risk of developing GVHD. Our group on the right shows that if you get checkpoint inhibitors after an allo transplant, you obviously develop very severe acute graft versus host disease. So suffice it to say is that if you're exposed to checkpoint inhibitors in the pre-transplant period, you're coming in with somehow a supercharged immune system. So can you capitalize on that hyperactive immune system to improve transplantation outcomes? And it is theoretically possible. So if you look at some PK data, it's actually surprising that if you get checkpoint inhibitors before transplant, checkpoint inhibitors are detectable in the serum of these symptoms up to 2 to 3 months after an allogenic transplant. And that's a That's a relevant observation. Remember, these patients are not getting checkpoint inhibitors after allo transplant, but if your last line of therapy before transplant was a checkpoint inhibitors, up to 2 months after transplant, these drugs are detectable in patients' serum. And it's important because if these drugs are detectable in their serum, if you test the CD4 positive and CD8 positive T cells of these checkpoint inhibitor exposed patients and compare them to patients who never had a checkpoint inhibitor, the T cells of these patients do not have PD-1 expression, meaning these are hyperactive T cells. And similarly, if you look at interferon gamma production of these cells, it is way more than the production you see in patients who never see checkpoint inhibitors. So these T cells are primed to develop or cause graft versus host disease. But a strategy is if you treat these patients with transplant and give them post-transplant cyclophosphamide-based GVHD prophylaxis, this interferon gamma production goes down. And in fact, with post-transplant PTCy-based GVHD prophylaxis platform, these patients produce more T regulatory T cells, which bring down the risk of GVHD. So maybe post-Cy platform is a platform where when this patients with supercharged immune system are coming in, maybe we can down-regulate the risk of GVHD and let the GVL play its part. So in that sense, Reed Merriman from Dana-Farber and Carmelo Carlostella in Italy led a retrospective multi-institution, multinational study, and our center also participated in that analysis, where they specifically looked at patients who had a checkpoint inhibitor exposure prior to getting an allo transplant. And the study had about a little over 200 patients. These patients mostly had disease in control coming into transplant. And the study included patients with haplodonors, unrelated donor, matched sibling donors, and not everybody got post-transplant cyclophosphamide. Half of the patients got post-transplant cyclophosphamide, half didn't. Now, if you look at risk of graft versus host disease, if you have checkpoint inhibitor exposure within 3 months of transplant, the risk of GVHD is higher, and it is consistent with the clinical data I showed that these drugs are detectable in the serum of patients for up to 2 months after transplant. So this cutoff has some biological basis. But these patients, compared to historical controls, have remarkably better outcomes. The relapse rates are now no longer sitting at 40-45%. Their relapse rates are around 18%. And in the curve on the left side, you can clearly see that there is a plateau in the risk of relapse. So maybe these patients with supercharged immune system come in with disease that is maybe more amenable to the GVL effects. But the transplant strategy matters. So if you see, I showed you historical data from Ena Sureda's group was the 2-3 year progression-free survival was a dismal 30%. In modern era with better supportive care, the CIBMTR data from our group showed that the 2-year progression-free survival was maybe 60%. Look at what it is sitting at now. It's about 80%, and the 2-year overall survival is 90%. And it doesn't matter whether you get a transplant from a haplodonor or not. What's important is prophylaxis with post-transplant cyclophosphamide. So I don't think so. The donor question is more important. The GVHD prophylactic strategy is probably more important. So I hope I have convinced you that in the modern era, if you have an access to a quality transplant center, if you have a double refractory classical Hodgkin lymphoma patients where you can control the disease with a subsequent line of therapy, I think allogenic transplant is still a viable strategy for these patients. Now, I would admit that allotransplant is not a modality for everybody, but it's very relevant in Hodgkin lymphoma patients because most of these patients are young and fit. But what about patients who are not allotransplant candidates or don't want one, or they don't have access to one? Or what about patients who relapse after an allotransplant with double refractory disease? How are we going to approach those patients? So in that setting, obviously, experimental therapy with chimeric antigen receptor modified T cells or CAR T cells is relevant. There is obviously not a lot of data with CAR T cells in Hodgkin lymphoma. This is the combined Baylor and University of North Carolina experience, where the two groups pooled their data for their strategy of CD30 directed CAR T cells. So the study included about 40 plus patients, and they were lymphodepleted either with fludarabine and bendamustine or fludarabine and Cytoxan, or sometimes with bendamustine alone. So in this CD30 directed CAR strategy, these are two curves of progression-free survival. So you see high response rates with CAR T cell therapy, but if you see these curves, and if you're a critic, you can say that these curves do not look like the CAR T cell curve you see in aggressive lymphoma patients, right? By 1 year, most of these patients, whether they got fludarabine or they didn't get fludarabine, in lymphodepletion, these patients relapse. So I think CAR T cell is in its infancy in patients with classical Hodgkin lymphoma, and definitely need improvement if it has to emerge as the definitive curative therapy. And there are obviously ongoing studies, not only with CAR T cells, but also with cytotoxic redirected T cells in the context of EBV and in EBV independent context as well. There are certain CAR constructs that are looking at improving outcomes on simple CD30 directed CARs. There are CD123 CAR T cells in development, because the immune microenvironment of Hodgkin lymphoma expresses CD123, and there is some CD123 expression on Hodgkin lymphoma Reed-Sternberg cells. So clinical results of that strategy is going to be important. The Baylor group is retweaking their CAR platform, and they are developing a CCR4 CD30 directed CAR. And the concept is that CCR4 will direct most of the CAR T cell trafficking to the tumor, maybe that will improve their outcomes. So that CCR4 directed CAR T cell that is targeting CD30, that trial is open in University of North Carolina. Dr. Natalie Grover was kind enough to share these slides with me. So at the last tandem meeting, they shared some preliminary data with the very first few patients that have been treated on the protocol. You do see high response rates with that construct again, and time will tell whether this construct will have more durability than their original data with the naked CD30 directed CAR. Now, beyond CAR, there are other relevant constructs in play as well. One interesting drug is called AFM13. You're familiar with bispecific antibodies in lymphoma as well as in myeloma. AFM13 is a bispecific antibody that binds to CD30 on the Hodgkin lymphoma cell, but the other end of AFM13 doesn't engage T cells, it engages natural killer cells. As a single agent, AFM13 has very little or no activity in Hodgkin lymphoma. So Katie Rizvani and MD Anderson combined AFM13 with pre-activated NK cells from cord blood. So these NK cells were pre-activated with IL-12, 15, and 18 to make them more immune competent. And then these NK cells that have undergone pre-activation were mixed with AFM13, and then they were infused to the patients. And their preliminary results show very nice signal of activity in these patients. So I think my slides are not advancing. I hope you guys can hear me.
Yeah, we can hear you. Yes.
Yeah, I think it's so this is, if the slide would advance, I'll show you that I'm going to reshare my screen one more time. So hopefully you can.
Yeah, we can see the slides.
Yeah. So it's if it moves to the next slide, which I think it's going to take its own time, in the first 6 or 7 patients that they treated, they showed nice responses. So this trial is ongoing, and I think it's a non-CAR T, non-allo transplant-based approach in patients with relapsed refractory Hodgkin lymphoma. I think it's an interesting platform. So you can appreciate that there are strategies to approach these patients with classical Hodgkin lymphoma. And I think my computer has decided that it's not gonna let me move forward. But the good thing is it decided that towards the tail end of my presentation, because the only slide that I have not shared is the conclusion slide. I will try one more time and see if I'm successful in sharing that. And if I am unsuccessful, we will call it a day and we will just go straight to your question and answers. Yeah. Okay, so I don't think that is gonna, let's try it one final time. So I think it's not gonna work. So I'll stop here. I don't think so you guys have missed any slides. And I'm grateful for your attention as well as your invitation and happy to take any questions.
Thank you, Dr. Mehdi. That was wonderful. Learned a lot. So let's have some questions. Dr. Krishnaratne.
Thank you, Dr. Mehdi, for a wonderful talk. So I have just two simple questions. The first question is, in India, we don't have the luxury of all these investigational drugs. So if a patient is clearly chemo-refractory and also not responding to salvage chemotherapy, is there any place to directly take him to allotransplant rather than an autotransplant? That is question number one. Question number two, to mitigate the relapse after allo, is there a role for a brentuximab, anti-CD30, post-allo?
So both good questions, right? So I'll start with the easier one about role of allotransplant in the post allotransplant setting. Unlike autotransplant, maintenance, not a lot of data in allotransplants. But the Children's Oncology Group in USA did a proof of concept brentuximab vedotin consolidation study in allos for Hodgkin lymphoma patients. They presented their results in abstract form. Long story short, yeah, I think it is a feasible strategy. And in the right patient, it may be the
Okay, we're having a problem. He got logged out. We'll see for a minute if he logs back. I think he's having difficulty in getting back to us. Dr. Manoj, are you there? Okay, I think in that case, just the information that tomorrow's webinars will start early. We are starting at 5:55 instead of 6:25. Tomorrow's webinar will start at 5:55. And thank you so much for being with us today. I hope you enjoyed and learned, and have a wonderful time with your family. And good night to everybody. Bye-bye.